For another show. This is Robert Caruso. Again this week I have Darren Prescott, CEO of Mobile Urodynamics Group. Welcome, Darren.
Hi, Robert. How are you?
Doing great. Thank you for joining us. Darren, last month we covered Mobile Urodynamics Group, what you do, and the fact that you are the nation's largest outsourced urodynamic testing company. This month I'd like to spend a little time covering the details of what's really involved in a urodynamic study. What's the process and the procedure itself in a little more kind of general terms, so our listeners, our urologists and gynecologists, have a better understanding of what's happening inside that exam room.
Okay. I think maybe we'll just go over what urodynamics is and what some of the individual tests that are a part of an overall urodynamics study.
I think that would be great.
Okay, so let me just take you through the initial urodynamic study and kind of a mile-high view of it, and we can go into more detail later on.
I think that would be great.
Okay. Well, first of all, we start off with a very basic uroflow, and that's really to identify any sort of obstructions or anything like that. At that point, once we've done the uroflow, we're going to begin the filling cystometry. So that's a CMG. And that CMG
what exactly is that?
Well, cystometry really is a study of the storage phase of the micturition cycle and provides information on compliance and stability of the detrusor muscle, capacity of the bladder, the transmission of sensation through the neurosensory pathways, and really the competence of the outlet. So what we do essentially is we fill the bladder up and we record pressure levels and anything else that needs to be recorded during that process. So
perfect.
We're going to take them through 4 initial stages of filling. The first is first desire, and that's really if you notice anything at all. Normal desire, which is if you were driving down the freeway, you start noticing you might start looking for an exit. And then strong desire, which is you're really looking for an exit, and if you don't find one soon, you know that you might have an accident. And then finally urgency, which is you just can't hold it anymore. And so during that process, we are measuring vesical pressure, abdominal pressure, and detrusor pressure. Detrusor pressure is just a subtracted pressure there. And then also the infused volume at each of those pressure levels. And so that's really the cystometry, as I said, at a mile-high view. I think it makes sense for us to go over that in much more detail later on for each of these, actually.
Yeah, we'll take another show to do that.
You bet. So now the other part of the process, during the cystometry, we're going to stop them usually at about 200 cc's of filling. And we are going to do, on our female patients, we're going to do a Valsalva leak point pressure. And we want to know at what point they leak. And we want to know that in not just a normal Valsalva leak point pressure, but we also want to do that reduced. And I think that's one of the things that gets left out sometimes is a reduced Valsalva leak point pressure. If the doctor's considering a sling, they really should know whether or not that sphincter is compromised prior to doing it. If it is, and they elevate the bladder and it's compromised, you could have a serious leak problem at that point. So we're going to really identify the level of stress urinary incontinence. We use a 3-level stress urinary incontinence guideline, and that really involves kind of mild, type 1, which is kind of mild, and that's a leak at pressures greater than 90 centimeters H2O. Then moderate, which is a leak at pressures between 60 and 90. And then severe, type 3 severe, and that's below 60 centimeters H2O. So that's not a lot of pressure, obviously, for them to leak.
Sure.
So that's the Valsalva leak point pressure.
Okay.
During the entire process, we are also doing electromyography. And so we're really evaluating the neural pathway system and really identifying if there's any sort of bladder sphincter dysynergia or anything going on there. And, obviously the majority of that happens, the important data anyway happens right at the part where the patient is going to void.
Okay.
So once the patient gets to urgency, we ask them to go ahead and void, and during that we record pressure levels, so we get a pressure flow study at that point. We're also identifying any sort of problem that might be occurring through the EMG, and once they're done voiding, we measure any sort of post-void residual. So if we filled them, for example, 400 or 500 cc's and they only voided 2, then we know that they've got a considerable amount of fluid still in them after they've finished voiding. We also do a post-void residual after the initial uroflow, and that really consists of actually placing a catheter and draining off any additional urine after their initial uroflow, and that tells us how much PVR they have.
Makes sense.
So that's kind of, as I said, a mile-high view of our urodynamic study, and there's a lot to it, and I think it makes sense to really dedicate some time to each individual's test and kind of what doctors are looking for and what the benefits are, probably more than we can get to today.
Well, I most certainly agree. It seems that Mobile Urodynamics Group really takes a very detailed approach to the process and conducting the urodynamic study. What I think we should do, Darren, is maybe for next show, let's spend some time on 1 or 2 of the different steps in the process and really break it down into detail of what's involved with them, what you're looking for, and most importantly, how it helps your urology and urogynecology clinics help their patients with proper diagnosis. And I think that'll be the next show's focus. But until then, we are out of time. Darren, thank you for joining us today.
Okay.
On behalf of Darren Prescott and Mobile Urodynamics Group, this is Robert Caruso. We appreciate you joining us this show, and we look forward to seeing you again next show.